So, okay, I hope you can see the screen okay.
Yes.
Health Information Exchange Webinar 5. Okay, so welcome to the 5th webinar in the series. We've been through the purpose of these before, but that's for completeness. In terms of the diagram, we're on the Health Information Exchange. If you go up on the left side, third from the fourth from the top. And it comes after the Standards and Interoperability session last week. And actually, Standards and Interoperability and Health Information Exchange are very closely related. So, the way I've structured this is, as usual, to give a connection to the WHO ITU eHealth Strategy Toolkit. And really then to look at the way in which health information exchange standards and interoperability issues are being addressed at an international, regional and national level, and also referencing the fact that increasingly there are consumer exchanges, sort of person-centered exchanges. And lastly, to also make the connection to the fact that interoperability, as we discussed last time, is also about the exchange of information and standards of good practice, not just about data and its meaningful exchange over a technical platform. So if we look at the strategy, in the section that deals with action plans, there's this very simple phrase, develop an integrated action plan. But actually, the requirement is to form a holistic action plan to try and come up with an overarching whole systems view as to what's going to be required. And that action plan needs to be framed, ideally, with reference to these 4 types of action lines. And I've used this slide before. I'm putting it up again because when you're thinking about health information exchanges, actually, you need to be addressing all of these action lines together. It relies on having good foundations. It's there to connect solutions. HIE exchanges are part of the new ways of motivating and supporting health systems, and they themselves require particular forms of governance relationships to be able to work well. So this is a bit of a scary diagram. It's in the strategy, and it's an example that actually comes from Australia, the eHealth strategy for Australia, published for 2008. And you'll see on the left-hand side, the headings of the 4 major rows are foundations, solutions, change and adoption, and governance. And then you can see the things that they were planning to do to support each of these action lines broken down into more detail. What it doesn't do is to show you the interrelationships between them, because that can become very complicated and kind of loses the effect of the diagram. But at least this gives you an idea of how, in Australia at that time, they were planning to address the whole system in terms of being able to support it with information and IT. And you'll notice that across the top of the diagram, we've got the years, so year 0, year 3, year 6, and year 10. And I just draw your attention to that because health information exchanges and eHealth strategies take time to put in place. And thinking about things in 3-year chunks is not a bad idea, and it helps manage people's expectations appropriately. So that in the first 3 years in Australia, they were describing this broadly as the time when they would connect and communicate. That was going to be the focus of their work over those 3 years. In the second 3 years, it was all about collaboration. And in the last 3, it was about consolidation. So that's at a very high level view, the way in which implementing eHealth strategies is indeed all about being able to exchange meaningful information. Now, if we look at the basic structure of a health information exchange, and this is an example from the Open Health Information Exchange community, and you've got the reference there. But I've selected it because it illustrates quite simply a number of key points. First of all, if we look at the bottom, there are a number of different points of service where requests can be made for a service. So you may need to interact directly with a clinical system, or a specimen that's been taken from you may need to be sent to a laboratory system. Hospital record systems will need to be drawn on. Community health workers, of course, will have also systems that need to be engaged with, and this can be done, as this diagram indicates, perhaps using mobile devices. And then pharmacy systems will be needed to order and receive drugs from. Now, that basically is kind of in a very high level generic way what's going on in the provision of healthcare. But if you now look at the top of the diagram from the left side, you'll see that, of course, whilst that's general, we need to know specifically who is the client that is requiring information to be exchanged, and by whom, the health worker, are they or with whom, in terms of the health worker, are they interacting, and where is this going on? And you remember last time we talked about health facility identifiers and the location code that's needed for them to know where they actually are. And then the description of what is done is really what the terminology service is there for. So this is where you're maintaining a kind of a terminology set that is mapped to, for example, ICD-10 or LOINC or SNOMED, etc., to say, well, this is what happened. And of course, what we are wanting to end up with in number 5 is a shared health record, where you've got what's called a normalized version of the content once it's been validated, so that the requirement is that everything that has been done for everybody, no matter what the clinical context is, where the work was done or where it was done, the data that is stored in a shared health record has been structured in such a way that anybody else who retrieves it from another place at another date to look after you, maybe you've got a different condition or a later stage of the same condition, they know in an unambiguous way what was meant when the previous entries in your health record were made. So that's the importance of having health records that are unambiguous. And the magic, in some senses, happens in the bit in the middle, the interoperability layer, because that receives all the communications from the point of service in any kind of health geography, and it has to orchestrate it with messages that are sent over the infrastructure between the requesters and the providers. And you remember last time I referenced the application programming interface, API, and I said I'd come back to it in this session here. And on this slide, you can see that if you look inside and in the interoperability layer that joins up the service requesters and the service providers, the application programming interface this is, in a sense, where it sits. And it is a part of the process of making sure that these translations about the different transactions that have been made are correct and can be understood unambiguously by the receivers and the entries into the shared healthcare record. So you've got the references there to follow up, and I think the open HIE environment is an informative one. And if you want a worked example, have a look at this reference that gives you an indication as to what they have done in Rwanda. And here you'll see that this diagram kind of is similar to the previous one. So you've got the interoperability layer in the middle where the magic happens, and then you've got the various provider systems.
Hi, Peter.
Hi.
Hi, Peter. Hi. You were cut for around 2 seconds. Can you repeat what you just said?
On Rwanda.
Thank you.
Okay. So just to say that in Rwanda, if you look at the references, you'll see that they have been using the open HIE architecture. And in the middle, you've got the interoperability there that I was discussing on the previous slide. And then you've got the various clinical systems at the bottom. And you'll see that they're provided by different sources. So you've got the Open Medical Record System, OpenMRS, TrackNet, that does a lot of work with mobile communications. And then you've got the various registers that are maintained in or by the Ministry of Health. And they have a very centralized system in Rwanda. And the Ministry of Health has the responsibilities for maintaining all those registers that you see there, but there is a reference to other national databases. And in the middle of what the Ministry of Health is responsible for, you will see the shared health record. So that's an example of what they're doing for real in Rwanda. But I've also pointed you to the example from the Philippines, where there's an HIE, I hope, in development, and certainly there was a very intensive workshop going on when I was in Manila last year on this topic. So again, there's another reference for you to follow up there if you want. So that's one of the two examples of the international HIEs that I wanted to cover. The second one is to do with integrating the healthcare enterprise, IHE, as it's often referred to. And this brings together users and developers of health information technology in a 4-step process. So step 1 is bringing the clinical and the technical experts together and defining some, as they say, some critical use cases for sharing information. Then the second stage is to get the detailed specifications made amongst the different systems using the appropriate standards. And as you'll see, we've covered, I think, all the relevant ones. Then in the third stage, the industry go away and they take these standards and specifications and the requirements that have been drawn up, and they implement them in their systems. So this is the requirements are called the IHE profile. And then in the fourth stage, they all get together in events called connectathons. And at these events, the performance of their system against the requirements is tested. So if we look at this diagram, which covers the process as a whole, you'll see that in the top left, the IHE define and publish the requirements, the technical specifications, the use of the technical standards is shown there, and then there's an implementation phase by the developers and the vendors, and then there's a testing that is done in the connectathon, and the results are then published in the product registry, which users and purchasers can consult and use, and then they specify the results in tenders and they test them for real in the marketplace. So that's the AeHIN process, and it's currently involving over 250 vendors. It's been going for more than 10 years, and connectathons are run in a fair number of countries now as well, so that the process is available for use by vendors that are operating around the world, basically. Now, just to unpack the standards bit, and so that you can see the connection between all the topics that we covered last Friday. This diagram shows you the core and security standards, the semantic standards, and the messaging standards. And I hope all of those names are familiar to you. And if you've forgotten what they are, go back and look at the slides that I shared last week, and they're all there. So you'll see it's got LBAP and SNOMED and ICD and DICOM, for example. But the point is, this is all about, and this is what AeHIN say, this is to improve the way computer systems in healthcare share information. And I have italicized computer systems because I wanted just to remind you that whilst that is absolutely true, it doesn't address the information standards that professionals and patients also need to enable them to be able to use what is unambiguous and meaningful data in an appropriate way. So the last slide on this bit about AeHIN was just to let you know that the ISO that we came across last week, and indeed the week before, has agreed some global standards for adoption that relate to the AeHIN integration profiles. And they've done them for particular domains such as cardiology, labs, patient care. I just wanted to kind of give you this to reassure you that the AeHIN process has now got some very serious international traction and engagement. You know, it is there for you to use, and it's got all the documentation that is needed, and you'll see there some data models which we touched on last time. But basically, it's got everything that you need to be able to check the relationships between how you can exchange documents, records, etc., lab results, etc., between hospital and community systems. So an important process that's been evolving for quite a while now began, I think, actually about 15 years ago, and was very strong in radiology, on the radiology side, exchanging of images. Anyway, that I hope is the right amount of knowledge to share with you about AeHIN in this context. But the last slide before we have a Q&A was just to make the point that whilst AeHIN is an international initiative, within regions such as Europe, there are also efforts going on to improve the exchange of information. And there's an European interoperability framework that has been developed, and they have come up with a model, and this is a high-level summary. The reason I wanted to share it with you was because I think rather helpfully it builds on what I've covered so far. So what we've been discussing so far has been very much to do with the IT infrastructure and the applications and information and care processes, making sure that you've got the systems architects involved, the software developers, the analysts and the information architects and kind of the engineering side taken care of, and that you've engaged with healthcare professionals and that you've got the right amounts of security and governance and standards and profiles, etc. But the important thing, or the helpful thing, I think, about the Antelope project's approach is that they quite clearly recognise the importance of having the top two layers seen as part of the whole programme as well. That is to say, the policy and the legal and the regulatory. And there are all sorts of stakeholders that may need to be involved if you're really going to deliver health information exchanges that work between countries within a given region. And so this is just to give you an example of some of the issues that need to be considered when that is the agenda. Okay, so you've got a reference there to follow up if you wish. So let me stop there and take any questions and answers, or take any questions and give you what answers I can. Thanks, Leah.
Okay. Thank you, Peter. There's a question here from Dr. Sambas. For health record exchange across systems, are there any procedures or protocols for data security and confidentiality?
Yes. See the previous references to the security standards and the confidentiality standards again, and the privacy standards are also being developed. And I've given pointers to the various ISO documentation so that you've got an idea about what is recognised at an international level. But it may very well be that in your particular country there are more local requirements for security and confidentiality. So I think the theme throughout this webinar series is to give you enough pointers so that you can follow up with some of the international standards and ways of getting the skills to support their implementation on the one hand, but on the other hand also saying to you, actually in your country or in your groups of countries, the regional example I've just been using, you may well have to recognise that you have some particular local requirements that need to be met as well. If that's clarification.
All right. Another question is, some of the attendees of this meeting are not really information system experts or those working in the field of IT. Can you give the simplest description on how a health information exchange happen and what are the benefits of implementing HIE on a national scale?
Okay. Well, I think the simplest is explanation. Just let me go over. This one here. I think the simplest picture is this one. That's how a health information exchange works, so that you have in the hospitals within your country, you have clinical systems, lab systems, hospital record systems. Across the community care services in your country, you will have community health workers and you'll have pharmacy systems too. And the purpose of health information exchanges is to make sure that when citizens and healthcare workers provide care, that the information that they need to provide that care is available, and the knowledge that relates to what has previously happened to a patient, and the knowledge that needs to be captured so that it can be used when that patient comes back again to the same hospital, or if they go to a different hospital, that information and knowledge is stored in a record system that has the capability of being used by any other organisation. To make that happen, you need something to join up. So, of course, you need a network. That's the core infrastructure standards that we discussed last week. But then on top of that, you need to have the standards that can deal with the ways in which the terms that are used to describe what has happened are held in a consistent way so that they're not misunderstood when somebody else looks at them. And you need to be able to identify unambiguously who the client or the patient was, who the health worker was that provided them with care, and where that care was provided, the health facility. So that's the basic structure of a health information exchange, and the value of that capability at a national level is that you can vastly, well, you remember in the first webinar that I did, I talked about the triple aim, where you're trying to support, to improve patient experience, you're trying to promote population health, and you're trying to reduce costs. Well, if you think about health information exchanges, that's really what they're addressing. So that when I, as a patient, go to any provider anywhere, my experience is that the person caring for me knows about me because they've been able to get the information about my previous care, wherever that happened to have been. So you're hitting the patient experience button. If you think about the way in which shared healthcare records, once they have been suitably anonymised, important proviso there, so that's why all the confidentiality and security issues are really important to get right. But if you're able to look at the shared health record, the anonymised shared health records of your whole population, you'll get a very much richer picture as to what the conditions are that they have, where they're being treated, and what the incidence rates are in different parts of the country. And you'll be able to relate it to the costs of providing that service, and that's the third part, to try and improve the cost effectiveness of care. So from the point of view of policy, actually health information exchanges are bringing together to benefit patients and policymakers, as well as the providers of care, a huge range of data, information, knowledge, and hopefully some wisdom as well. So you don't need to know the detailed technicalities of how this works at all, but you do need to know enough to know for sure that this is indeed really very important life-saving and money-saving activity that should be supported. And you need to know enough that it is, to understand that it is complex, and that a whole range of different sorts of skills are going to be needed. And I hope that this webinar series will enable you to get a feel for the issues where you yourselves may need to develop your skills, or the sorts of issues that those who are responsible to you will need to develop to enable them to get the skills to go and play their part in orchestrating this very rich, interesting, and really important health ecosystem. So I hope that's an answer to a very good question, I may say. Thank you for that.
Okay.
Yeah, if that's okay, I'll move on so that we stick to time, and if people have got other questions, I will be more than happy to come to them when we get to the next Q&A and sharing session, because I don't want to step too far behind schedule.
All right.
Because,
I will just ask for the other questions on our next Q&A. You can go proceed to our next slide.
Yeah. Okay. Thank you. Okay. So now I wanted to give you some examples, largely drawn from the USA, actually. So this is a country, quite a big country, but a country's approach to addressing health information exchange. And, you know, they are being pushed into this because they're spending 17% of their GDP and growing on healthcare. So there's a major problem that is growing all the time in the States. And at long last, they've realized that they need to have a better standards and interoperability framework to enable them to achieve the benefits that I was just giving in relation to that last question. And as you'll know, in the States, of course, you have also a very strong private sector as well. And this framework that they've been putting together pulls in both the public and the private sector. And you'll see that the flow from left to right relates to issues that I've just been covering, for example, with the AeHIN. So use case development, trying to align the concepts, agreeing what the implementation specifications are, coming up with some reference implementations, and then the certification and testing process. And you'll also see that they have got some, separate but important activities for standards development and for some pilot demonstrations. And all this sits on top of the use case development, tools, browsers, just getting the tools and services together to enable these things to happen. And that they have a standards and interoperability architecture that is being refined and managed all the time. So that's why last week I was, on Friday last week, I was trying to, in the session on standards and interoperability, complement what I'd said in the lecture on the Monday about architecture. So you need architectures, standards that enable interoperability, and then you need a testing process that can deliver actual exchanges of meaningful information. And that is what we're focused on this week. In a sense, the ways in which the standards that we've been discussing can now show their value by enabling information to be exchanged. So in the States, they have this Health Information Exchange Initiative, and basically there are three layers to it. Firstly, there's the directed exchanges, then the query-based exchanges, and then the consumer mediated. And I'll talk about each of those in turn just now. And to some degree, the information that is needed to support those three different but complementary types of information exchanges are available today in the States, but they'll also be available online if you want to look, and I've given you some links if you wish to do that. So let's now look at the directed exchange. So they have a direct project. So you can see, first of all, that it was launched pretty recently, March 2010. But this project is to enable authenticated, encrypted, so secure and accurate information directly to a recipient that is known to the sender and trusted, and to do that over the internet. So they've agreed some specifications for this, which include the secure health transport specifications and the messaging protocols. It's based on the AeHIN that we were talking about just a moment ago, and it's very flexible, so that you can do with everything from just plain unstructured text to much more structured continuity of care documents. But this project does not support finding out, where somebody may have been treated. So if I come into the direct project hospital and I've been seen previously in a place that somewhere else that this hospital doesn't know about, there's no way that they'll be able to get any information about me from that place. They'll only get it when they have already set up a direct one-to-one relationship with another hospital. So this is kind of the simplest example of the way in which health information can be exchanged between two consenting hospitals. All right? But slightly more developed and complex is the query-based eHealth exchange. And this works with hospitals or medical groups who sign up to a data use and reciprocal support agreement, a DIRSA agreement. And in the States at the moment, as of January of this year, they had 800 hospitals and 6,000 medical groups who had signed up to the DIRSA agreement. And what that means then is, I'm now hosting this event. Okay, let me keep going.
Go ahead.
You're right, Elia?
Yes, go ahead, please.
Okay. So in the States now, you've got about 100 million patients, roughly, who are being covered by this query-based health exchange network of hospitals and medical groups that have agreed to data use and reciprocal support. So they've launched an exchange product testing program very recently, March 2014. So I just wanted to share this with you because it gives you an idea about another way of evolving the process of a health information exchange, which is in essence to develop a data use and reciprocal support agreement and to get the different public and private hospital and community services to sign up to it to enable then any data that's been collected about any patient within any of them to be available to any of the others who want to find out about it. Right? So that's kind of the next level of evolution, and that's being delivered by the Health eWay program. That's what it's called. Okay. So the third one is the consumer mediated exchange. So basically, up to this point, when I've been talking about health information exchange, I've been talking about the health sector and health professionals exchanging information about patients. The consumer mediated exchange actually is involving patients as active partners in the process. So they can actively participate in their own care and its coordination by providing other healthcare providers with their own health information, identifying, correcting wrong or missing health information. So people usually do know what's right and what's wrong about their own health record. Correcting incorrect billing information is also an important component, certainly in the States, and tracking and monitoring their own health. And what's being described as patient-generated health data, PGHD, is becoming of increasing interest now in the States. So this is health-related data that's been created, recorded, or gathered by or from patients or family members or other caregivers to help address a health concern. And this is a reflection of the fact that in many health systems, it's being recognized that patients are becoming increasingly well-informed. They have increasingly a range of technology available to them or to someone in their family that can be used to connect them with the rest of the health information system, and that they can then contribute to the exchange of information about their own care. So this is again just to flag up to you that there is an increasing demand for health information exchange to be concerned not just with illness, but with wellness. And as the little subtext says there are over 1 billion adults overweight worldwide, and the Continua Health Alliance has been set up and has been a very active promoter of information exchange between individuals and their wellness teams, which may be in the public or the private sector, to enable better knowledge about their everyday life and lifestyle to be made available and fed back to them in ways that can encourage or coach them to improve their levels of fitness, which may involve weight loss, for example, or better diet, or ways to sleep, or whatever, or to monitor their blood pressure. And as the use of mobile technologies, personal mobile technologies, becomes more widespread, the opportunities to enable all citizens to become active participants in the healthcare ecosystem is growing a great deal. And Continua have got already now a large number of interfaces and standards set up. Now, you'll see on the left side, we've got all the different personal devices that may or may not be available in the patient's home or that they can have access to. And then, in a sense, the equivalent to the interoperability layer is the aggregation manager that sits in the middle. And then, via the use of the standards that you will recognize, even if you don't need to know the internal workings of them, but you need to know their importance, it's through the use of those standards that the information about the citizen recorded on their personal device can be shared and exchanged and stored on their health records. And that requires perhaps mediation through somebody, in a sense, sitting in the middle to record, to make sure that what has been sent by the patient is actually stored in a meaningful way, or it can be done directly. So you've got a direct and an indirect route. And that, I think, gives you a flavour of the way in which health systems are evolving, that the engagement of citizens using devices that they've got, their mobile phones or other mobile medical devices that they can either buy or hire or be given or loaned, is completely changing the way in which the patterns of ill health and the predictability of ill health is being changed. And that becomes possible because the hard work has been done to develop and evolve the necessary range of standards to support the different types of interoperability. Okay, so we are just beginning to see now, I think, some of the real benefits that are beginning to be realized after many years of hard work by technical experts, but the benefits, I think, are now becoming much more evident to ordinary citizens and patients, as well as to healthcare professionals and policymakers. So I think that now leaves us plenty of time for a Q&A session. Okay, so back to you, Alia.
Thanks, Peter. Just want to go back to this question from
Yeah.
Cambodia, from Silan Nuon. Is there any template or sample of use case documentation of different systems for IHE? Is there any template or sample of use cases documentation of different systems for IHE?
Yes, probably, but I couldn't point you to it directly. I think if you pursue the links I've given you, you'll find that the IHE site can give you examples of the companies and countries that have completed various connectathons, and certainly the companies will share their performance in terms of the outcome of the work on connectathons. But if you want to go to find how HIE is working within a particular country, then the best thing to do, I think, would be to follow up the links that I've given you in the States in particular. So the health eWay URL that I gave at the bottom would be one, and the healthit.gov policy references also have links to quite a wide range of examples. But if you're asking me, is there one place where you can go to where you've got all the different examples of HIE in one place, I haven't come across it. But I think I've given you enough for you to be able to retrieve probably enough to make some useful decisions.
All right. So at the moment, we are pointing out a lot of information needs when it comes to articles and resources on implementation. Maybe AeHIN could have one big project of scanning this IHE projects and experiences, and maybe we could come up with a book or with a resource to share to our members. So I look forward to that and to the positive participation of our members. So let's go to the next question from Dr. Sambat again from Cambodia. Is DURSA, DURSA, open source, and how do we access it?
No, DURSA is not an open source thing. It's been developed specifically for the USA, but you've got link. If you just Google on DURSA, you'll find pointers to the organisation that's been involved in doing it. And on the site that they've got, you'll find examples of the DURSA agreements. So I think you would be able to look at those and adapt them for use in Cambodia. And bear in mind, of course, that they will be developed for a very much more complex political healthcare system than you have in Cambodia. But the basic ideas, I think, will be there for you to look at and to translate and reuse and refine in Cambodia.
Okay, thanks on that. A question again from Cambodia, from a different person. As for policymaker, this is from Sila Nun. As for policymaker, should we have a central point for exchanges, or we just let the health system exchange among themselves?
Well, you'll see that I've given you two examples in the presentation that I've just given, and that give two different approaches. If you take Rwanda, a small country, there's 15 million people, but they've got a very centralized system with everything being controlled by the Ministry of Health, and their economy is very strongly supported by the donor community. So a great kind of public sector and NGO donor framework there, and a centrally managed health information exchange. On the other hand, at the other end, you've got the United States, where you have an effort being led by the Office of the National Coordinator for Health and IT, but they don't have any nationally mandated system that everybody has to use. What they've been trying to do is to encourage their healthcare providers, whether they're in the public or the private sector, to agree the ways in which they will exchange information. And they've been offering them a variety of incentives to do that, because the way in which the United States' health system works is much more a reflection of the interests of the private sector in being able to sustain their own healthcare businesses. So they have to be given incentives, in a sense, to comply with the use of standards that actually lead to benefits for citizens in being able to get joined up care. So that's why the DIRSA arrangements is a very kind of decentralized approach to health information exchange, and it's up to individual health organizations to decide whether or not they're going to join up with the Health E-Way project. But the US is an interesting country in the sense that, you know, there is a lot of work that is really only just getting underway in terms of evolving a national approach to information, to health and health information. Up until the last 5 years or so, it's been a very kind of decentralized, hands-off approach that has been taken by central government. In the UK, we have a much more, well, a smaller country, and we've got an approach in which neither a centralized nor a decentralized solution has yet been found to be the most effective way of doing things. So we seems to me, are constantly shifting between the two. So to come back to the situation in Cambodia, I don't think that there is one right way of doing this. I think in Cambodia, as in any other country, you need to just take a look at what's going on in other countries, look at what seems to be international best practice, and then consider how things are for you and decide the direction that you want to go in. Having said that, I would urge any country like Cambodia that has got a large presence with the NGO community, who are in many cases actively involved in the delivery of healthcare, to make sure that they are seen as part of the process and don't develop their information standards in isolation. So, for example, in Kenya, 50% of the healthcare in Kenya is delivered from the mission hospital sector. And they have good systems, but they are run in quite a different way from the government system. So they've got some particular challenges there that they need to get over. So I'm sorry there isn't a black and white answer to that excellent question.
Okay. We go to the next question so that we can cover everything. There's a question here from the Philippines, from Dr. Portia Marcelo. Could you discuss an HIE that enables drawing up public health aggregated data and not data coordinated medical care?
I think the health information exchanges have been predicated on the records of patients. So they're not, you wouldn't call a system that takes the results of surveillance activity of health in particular communities as part of a health information exchange, if I've understood the question correctly. So health information exchanges do rely on records-based data, but once you've pulled them together and you've anonymized them, you can then use them for a whole variety, as I was saying before, of public and population health purposes. So I can't give you an example of an HIE directly based on population health, because I don't think that's how they're organised and structured.
All right. I think the question is on drawing up public sector-oriented health data aggregation. On how could this be possible? But I think you have just what you have said.
Public sector health organisation. I mean, in the sense of information records, patient record-based information, where the patient has been seen in the public sector, public health sector. Yeah, that's you know, the examples of that I've been quoting are examples in many cases of that. That's not a problem, but I thought it was to do with the population health aspect. Perhaps I misunderstood.
Okay, that's fine. So we have another question from Muhammad Solihuddin. Is it legal to hack into a vendor or provider product if they don't provide API for data interchange?
Is it legal to hack, did you say?
Legal to hack or go into, I think this is to go into the vendor provider product if they don't provide API for data interchange.
No, it's not legal. No, it's definitely not legal. Because, I would say the lesson to be learned from that is to be very careful that any vendor that you deal with has within their products the capability to support open standards, because it gives you the opportunity then to swap in and swap out the different modules that may or may not be required in delivering healthcare in your particular setting. So if you've got a vendor that is not supporting APIs between certain components of the health system, let's say you've got one that locks you into a particular way of dealing with pharmacies with particular drug codes, I would say, you know, beware before you sign anything with a vendor that they support open standards, because if you do that and you are then not happy with the ability to make inquiries of drug database solutions, you then have the option of swapping out what they provide and inserting something that another vendor has provided. So the short answer to the question is no, you don't have the right to hack into APIs, but make sure that the vendors are supplying you with solutions that, first of all, have the APIs that you want, but secondly, that they are supporting international standards. What you do not want to do is to get locked into one particular vendor. You need the ability to get the balance right between the advantages of having very good quality integration between modules in any solution because they come from one vendor. That is more easily done if everything is provided by one vendor. But on the other hand, if you get locked into that, then you can't take advantage of other solutions that come along that actually perform much better. So you need really to know enough to make sure that in discussion with vendors, you've got the right, that you're comfortable with their approach to the standards and interoperability issues, so that you can have other providers being able to offer their solutions if they become more cost effective. So pay attention to the small print of the contract.
All right. So in the very first place, they should be aware of the terms and, of course, what they would be expecting in the terms of their contract. All right. We don't have any other questions. We could proceed to our next few slides. Then before we close, some summary from your end. Thank you.
Okay. Thanks, Julia. So just wanted to share some of the capacity building resources with you that I've come across, and the ones that I've picked out are the ones where there's a reasonable chance of being able to get some information about online qualifications. So the Integrating the Healthcare Enterprise, they've got some on-demand documents, and quite a lot of material has been published about that on their wiki. I haven't talked about Canada much, but again, if you're wanting to look at a country that has actually done a lot of really good work in health information, Canada is a good example. And they've got some information available in terms of their online education that might well be worth looking at to do with standards and education. And then there are other offerings that are available to cover EHR, picture archiving systems, IHE, organisations like OTEC, and health IT certification. Again, I thought either you or colleagues that work with you or for you might be wanting to have a look at those. But as I've said, these are just some indicators, and there are others, but not as many as you would hope, actually, in terms of having resources available online. And again, I would say this is something that, you know, AeHIN might want to be looking at quite seriously, which is, in essence, how within your region, if I can put it that way, you are able to get together the countries that do have a common requirement for some capacity building and training, and approach the organisations that offer it, perhaps in other countries like Canada, for example, to provide that sort of material to you, either in person or online. I think that there are, my guess would be that if a consortia of countries within a region were approaching the skills and capacity building organisations that have been working in Europe or in Canada and the States, you'd have a more likely to get a constructive response from them than doing it on a one-by-one basis. So that might be another area where AeHIN has a role to play. The next slide I wanted to share with you because I'm kind of conscious that in the approach to eHealth strategy development and in the material that I've given you so far, I haven't really, I feel, made enough reference to the impact that mobile phones and mobile devices are having. And I think this is going to be a really important part of the eHealth picture as things evolve over the next 5 to 10 years, particularly when smartphones become affordable and tablets become affordable to citizens in most places. I think this will really change the boundaries of healthcare, and that's why I've been taking the opportunities where they presented to remind you that citizens are increasingly becoming active and engaged people in their own healthcare and in the health system. So I wanted to point you to, first of all, a useful resource for mobile health solutions, which if you haven't checked it out already, you might want to do so. Health Unbound, the hub, there's the URL there. But they have run a tech change course, an online certificate course on eHealth, mobile phones for public health. And that's just a snapshot of some of the material that was being presented on it. Now, I think this is pretty embryonic. There really should be much more training available, I think, for people who can see the potential for mobile devices to be used. And so you may want to contact Hub, have a look at that and think about ways in which it could be adapted, or encourage Hub indeed to come up with something that AeHIN might be keen to see them testing out within your region. And then, of course, there's Hinjix. And I did want to, again, I know I've referred to this before, but I just did want to remind you that you do have on your doorstep, so to speak, a really very valuable resource, one that was covered in an AeHIN hour that was done a little while ago, and that's where these slides have come from, so I've referred to. But in there you do have, for example, a single point of access to global eHealth knowledge. There is the potential there for you to open that portal and engage with a wide variety of resources. You can, as it says, it's possible to find reusable information, contact trusted experts, look for new opportunities, access global programs, and understand what's going on locally. And that obviously only works well if knowledge, lessons learned, successes and failures, as well as tools and experiences and opinion, are all shared. So it's an initiative that brings people, projects and resources together to enable global collaboration, and it's free. So it's a compelling value proposition, it seems to me, and one that I would encourage you to make full use of, because it can help you do a lot of things. And in a sense, this is the gist of this webinar series, that by sharing knowledge, exchanging knowledge, you can reduce time and cost. So I hope providing you with some knowledge, sharing with you what I know, in the hope that it will help you meet the triple aims of delivering healthcare. So certainly reducing the time and cost that it may take to deliver solutions, improving the population standards and the patient experience. So it's a resource to help you find the right project managers for the jobs that you need doing, and you've got an idea from or you will, by the end of the workshop, you will have a good idea as to the range of project management skills that may need to be required and where they can be gained from. And I hope that it helps engage the local experts in the global community. And I referenced the workshop that was held in the Philippines to do with the Health Information Exchange last September. And that was great because you had the people locally from within the Philippines, from the region, as well as the global open health information exchange community, all in the same room and sharing knowledge and expertise with a focus on bringing that together to benefit the HIE initiatives in the Philippines. So the overall intention, therefore, has been to enable you as of the series. This is to help you as policymakers to increase your capacity for countries to implement and sustain a national eHealth strategy. So this webinar series is a contribution to meet that objective for AeHIN and HINGIX. So I hope we're making some progress, at least in that direction. Okay, so then let me just share these questions, quiz time questions with you. I hope they are all understandable. They refer to things that I've covered in the questions and in the answers, really, that I've been giving, and in the text that I've been talking about and illustrating. So I hope you will find them a useful way of revising your knowledge of what I've been trying to cover. And just to say that the last question, is your country implementing an HIE, yes or no? There's no right answer to this question at all. But the purpose of this particular webinar, and indeed of the series, is to help you engage with some of the issues that you need to be thinking about as you try and develop an eHealth strategy that can actually be delivered in practice, and what are the more detailed issues that need to be understood, and what are the sorts of skills that need to be on tap to resolve them. What are the standards that will be relevant, so that whether you need this information yourself or whether you need to know enough to know that people working for you, directly or indirectly, do need to know about them, will be really helpful. Sorry, can I just let me go on mute for a moment?
Thank you so much, Peter, for that wonderful presentation on health information exchange. And I would also like to point out that health information exchange doesn't talk about health records per se. It also includes resources and artifacts on health, which could be shared to everyone and could be sources for learning, just like the Health Ingenuity Exchange, which was pointed out a while ago, which is a very good knowledge base of all articles, access to all use cases and experiences written on paper and basically shared to everyone. So I think that's it. We're okay on our on our lesson 5 on HIE, and I hope that everyone could access all our quizzes, slides, and videos. For those who were not able to attend last few sessions. All of those are uploaded in www.aehinacademy.org. And you could also access the slides, the videos at our YouTube channel, AeHIN 2011. So if you want to get the latest videos on AeHIN Academy, please subscribe to the channel. And for those who have not yet created their accounts yet and are still running to be in the course, please visit www.aehinacademy.org and create an account and enroll yourself with the enrollment key DreamHost Moodle 123 with exclamation point. Thank you so much for being with us this afternoon. Again, this is Aliyah Evangelista from the Asia Information Network. Yes, Peter?
Sorry. I am expecting a call in about 10 minutes' time, and I thought that was somebody calling me early, which is why I picked it up. So my apologies for that. And in fact, it was somebody saying, "Is that the Citizens Advice Bureau?" So no, although I am advising citizens, but I'm not a Citizens Advice Bureau. So my apologies. But are there any other questions that people will have to offer, or are we all good for today?
There were some comments a while ago that I am looking at. From this is a question from Dr. Martha O'Malley. I wonder about the challenges and measures to ensure accurate, aggregated public data for countries without a national identification system. What a very good question, because many countries still doesn't have a national ID system. So again, I repeat the question. What are the challenges and measures to ensure accurate, aggregated public data for those countries without a national ID system?
Yeah, quite considerable. There are, well, if you don't have any sort of national ID, and you can't identify individuals uniquely, whether that's from a civil society point of view or from a health sector point of view, then it is difficult, obviously, to get accurate, aggregated information. However, of course, it depends on the purpose that you're trying to meet in having the aggregated data. But I think that from the point of view of policy decision making about public health related issues, you can, of course, gain a huge amount from sample surveys that have been carefully crafted and delivered. So yeah, depends really on the purpose of needing the information. The other thing that is relevant, I think, is paying particular attention to sentinel events, certain kind of key indicator conditions to help in decision making. And the other possibilities that are beginning to open up now are the use of big data and analytics, where you can take actually very large volumes of poor quality data, but be able to analyze that in such a way that the algorithms reduce the reliance on individual bits of data, but give a pretty accurate assessment of the overall issues that are being uncovered within the data as a whole. So big data and analytics, I think, may be an opportunity for the public health sector to get over some of the challenges that you have with current data. But the best solution, I still think, is to have a good quality systems for identifying individuals unambiguously, and at the same time, trusted approaches to anonymizing and securing that information so that you can really use it to good effect. One of the issues that you will find is that even if you do have good identifiable data for individuals that is anonymized, you can still, in effect, identify who they are simply by knowing 6 or 7 different aspects about the population in question. So one of the issues here in the UK is in the care.data approach, which is using anonymized health data about individuals. But the feedback is that actually you can find, if you wanted to, you could find out who the particular individual is because there would only be one person that, for example, was born in a particular month, had a history of, broken leg with kidney failure, and was aged between 60 and 65. Although that data individually is anonymized, actually when you bring it together, it's clearly this particular person. So there are also some significant issues about the way in which data can be anonymized and pseudonymized. So it's not a straightforward answer, but quite a lot can be done, and there are different ways of doing it. But primarily it depends on why you need the information and what the questions are that you're trying to answer.
All right, thank you for that very comprehensive answer. I think we're okay on our lesson 5. Dr. Martha Jane Umali says, thank you very much to all this information. So I think we're okay for our lesson 5. So I give back the floor to you for the next trailers of our lesson 6.
Okay, so the number 6 is all about delivery. And I was saying just a moment ago that by the time we finish the webinar course, you'll be familiar with the program management and the project management skills that are going to be needed to deliver the programs. And that's what I'll be discussing on Friday. So I hope that you and your colleagues will re-engage, and I look forward to rehearsing these issues with you on Friday. Okay, thanks, Elia.
Thank you so much, Peter. See you all in our www.aehinacademy.org for your quizzes. All quizzes are available on that page. Thank you.
Right, thanks all. Thanks.